Good morning, everybody. It's a great pleasure and privilege to be at this meeting, and I'd like to thank the organisers, Valerie, Claire, and the team for inviting me to give this talk, which was, for me, was quite a challenge. Can we prevent rhinitis? And I found this paper from Sweden, which is just recently published, and in a sense, this is one of the main messages. And that is that we know that smoking is bad for you, and we know that smoking in pregnancy and in early life is bad for you. And this paper that was published recently I think it was in 4,000 children in Sweden, followed up over a period of 16 years, showed that if you are smoking in pregnancy, that is just one cigarette a day or more, then there is an increased risk of rhinitis in early life. And this cohort was followed up for a period of 16 years. So what was known was that tobacco smoke during pregnancy and infancy is bad for you. What the study adds is that this risk for certain allergic conditions can extend right up to 16. These children were followed for 16 years. And if we look here, this is the odds ratio for developing either asthma, rhinitis, or eczema from 1 year up to 16 years. Then what we can see is for asthma and rhinitis, the open circles and the grey circles, is that you can see that there is an increased risk during the first 4 years of life. And also, if we look at smoking exposure during infancy, again, in either parent, 1 cigarette per day or more, then we see an increased risk in terms of rhinitis and asthma, but interestingly not in terms of eczema. But if we look at 16 years, then this is reversed. What we see here is that there is an increased risk in eczema that comes up here during 16 years of life. And that's for smoking during pregnancy and during early childhood. This is really bad news, and one good message for your patients, and if they want to avoid rhinitis and asthma in their children, is not to smoke during pregnancy or early life. Now, this is a very famous study by David Strachan that was published in 1989 as a letter in the BMJ. It's been cited 4,500 times, I checked last night, in the academic literature. This was a remarkable study. What David showed was that the risk for hay fever and for other allergic problems are increased according to the number of siblings that you have. And so increasing number of siblings is protective. The other thing you'll note from this is it was in 2 birth cohorts. This was in the 1958 birth cohort, and this was in the 1970 cohort. So the 2 messages on this slide are, number one, the increasing prevalence of rhinitis during this period, and secondly, and of course this is a cohort effect that has continued over the last 40 years, and secondly, the fact that having siblings, older siblings, is protective, and raising the question that hygiene and exposure to bacterial components in early life may be protective. So this is the famous picture from Erika von Mutius that shows that one of the big risk factors or protective factors is exposure to a farm environment. And if you're a baby, then you only have to be exposed in the first year of life to raw milk in a barn to afford protection against the development of allergy and hay fever and asthma. And you could say, what is it in raw cow's milk that might be protective? And of course, it's absolutely stuffed full of organisms, mainly good organisms, lots of lactobacilli, lots of bifidobacteria that we see in yogurt that's available on a regular basis, but also nasty bacteria. And you'll never get anybody or the regulatory authorities to prescribe raw cow's milk as a form of treatment. But nonetheless, this is a very powerful protective factor. Now, I'm not going to ask you to look at the results of this trial, looking at associations of milk exposure with asthma, atopy, and hay fever. What I'm going to do is just focus on the hay fever outcomes for you. And essentially, if we say that you're exposed exclusively to shop milk in weaning in the first year of life, then your hay fever expectancy is ratio 1, and being exposed exclusively to farm milk, you can see there is a very marked, in statistical and epidemiological terms, a very strong protective effect of farm milk. If you boil the farm milk, this effect is completely lost, suggesting that clearly there's something in the milk, live in the milk, that is affording protection. And then however you dice it after that, if you looked at first unboiled milk before the first year, after the first year, daily unboiled, or even less than daily unboiled farm milk in the first 6 months of life, then you get a highly protective effect. But we can't give unpasteurized milk to prevent rhinitis or hay fever. So what can we do? Well, we can give probiotics. And I've summarized the 15,000 publications on probiotics and prebiotics and risk factors for various allergic diseases on the one signal that I think is important, and that is that if we look at the use of probiotic supplementation in early life compared to no probiotics, and we look at the risk factor for atopic eczema at age 4, then the studies are, there's a lot of heterogeneity. But if we look at decreasing the risk to the left of the line and increasing the risk to the right of the line, we can see in this nice study published by Bob Boyle and his colleagues from Imperial that there is a protective factor. So probiotics protect against eczema, but the short answer is they do not protect it against hay fever and against asthma. At least there's no strong evidence to suggest that probiotics will prevent the prevalence of either of these two conditions. And this is just to highlight this risk factor. It's a modest reduction, around about 22% reduction in risk for eczema, but we do not see this for other allergic conditions. On going through the literature, I saw this study, which I think is really a very important study. It doesn't give conclusive evidence. It's an observational study. It's not an interventional study per se. But I think it gives some really important clues about how we may prevent asthma and also rhinitis. But this was focusing on asthma and allergic asthma in particular. And this is the so-called MASP cohort from Germany over a period of 20 years. 1,300 newborns, 5 German cities, followed up for a total of 20 years. And I really would encourage you to read this study under the guidance of Ulrich Wahn and Susanna Lau. And these were the very interesting findings, the avoidable factors. If you've got a parent with asthma or rhinitis, you're more likely to develop rhinitis. If you come from a poor family, it's a problem in terms of developing rhinitis or asthma, but you can't do anything about that. But if you start daycare either early or late, then you increase the risk of developing physician-diagnosed asthma. If you receive usual early childhood vaccinations, mumps, measles, rubella, BCG, and also encephalitis virus protection, you reduce the risk of asthma. And again, mothers who smoked during pregnancy, there's a clear increase in risk of developing asthma in the first 20 years. This is time to onset of first diagnosis of asthma. So the summary from this paper is that the following might prevent or delay asthma: avoiding tobacco smoke during pregnancy, receiving vaccinations in early life, and starting daycare between 1.5 and 3 years is protective. This is U-shaped protection. And of course, the concept is that at the age of 2 to 3, exposure to infection in the daycare setting may be protective, rather like the farm environment. Whereas, disappointingly, any aspects of diet, breastfeeding, pet ownership, presence of siblings, passive smoking, unfortunately, this did not come out as being significant. So at least that's hypothesis generating. So what about use of immunotherapy or other methods to prevent rhinitis? Well, prevent. Treat, yes. Prevent. That was my brief. Very tricky. There are 2 studies. And what we can think of here is the atopic march in terms of high-risk infants, sensitization, and then exposure and development of rhinitis and asthma. There was this study published as a letter in JACI from Pat Holt, very prestigious group of investigators who started a study. Initially, the pilot study just looked at 50 patients, and this was children randomized between the age of 12 and 30 to receive 3 sublingual vaccines combining house dust mite, grass pollen, and cat as the dominant early environmental allergens. And you can see here the amounts. These are respectable amounts of allergen that were included in the vaccine, and they were followed up for a period of 4 years. The results were very disappointing. If we looked in terms of, at 4 years, in terms of allergic sensitization, asthma, sensitization to different allergens, the results were, these are the p-values here, show that there were no significant p-values. If they looked at the uncorrected p-value in the per-protocol population, very dangerous post hoc thing to do, but again hypothesis generating, what they showed was, interestingly, that there was an increase in IgE to house dust mite and grass pollen, which is what we see during conventional high-dose immunotherapy in adults as an early signal that the immune system is actually seeing the vaccine. And the big problem with these young children is actually getting something that will stick in the mouth for 2 minutes in order to confer immune protection. And I think that was the problem with this study. The second study of prevention using immunotherapy came from the Isle of Wight, Dr. Hassan Arshad and his colleagues, and he took earlier children. You all know from the LEAP trial, the peanut trial, you bring in peanuts at 6 months of age and you afford protection against developing peanut allergy. What about if you give house dust mite immunotherapy to at-risk children in the first 5 to 6 months of life? And you randomize them to either placebo or house dust mite over a period of 1 year. Well, there was a very modest signal. What we can see here is that 1 year there was a reduction in sensitization to any allergen in the group that received the house dust mite in the first year. This was on a twice daily basis as a sublingual drop, whereas there was absolutely no change in terms of reported wheeze. But in terms of prevention, we're talking prevention, primary prevention, maybe sublingual immunotherapy. There's a signal here in these 2 early studies that we can prevent sensitization, and whether or not that might translate into protective effects, we'll wait and see. Now we're moving on to more secure ground. If you can't prevent the disease by preventing sensitization, can you prevent the progression of the disease? And 10 years ago, the PAT study published that subcutaneous immunotherapy was protective when given for rhinitis and following patients up in developing asthma. And this trial was a so-called GAP study with Erika Valaverta, a group of pediatricians in Northern Europe. This was 812 children were randomized, were screened initially in 11 countries throughout Europe. And it was a very simple design. They were randomized over a period of 3 years to receive the so-called Grazax. This is the SQ standardized grass allergen sublingual tablet between the age of 5 to 12 years. They were given the treatment for 3 years, then followed up for 2 years afterwards. And this was an extremely well-performed trial. You can see that 800 went in and over 600 came out. So over a period of 5 years, they managed to keep about 76% of patients in the trial. Now, the primary endpoint was disappointing, and this was time to onset of asthma by the protocol definition, which I don't have time to go into. But essentially what this showed was that if we look at here, the proportion of patients diagnosed of asthma during the 2 years off treatment, there was no statistically significant difference between the 2 groups. But the important point was that the prevalence of asthma was much lower than that predicted, the children that went on to develop asthma. So they didn't really have the opportunity. If you look at this is 39 out of 40. Only 9% of the kids developed asthma, and the study was powered on 25% of them developing asthma. And what was interesting was that if you look at their symptoms of asthma, as opposed to time to onset of an exacerbation of asthma, then there was a statistically significant difference between the 2 groups. And what was interesting was that if you look at rhinitis as an outcome, what we have here is the combined the symptom score throughout the pollen season over a period of 5 years, 3 years on treatment and 2 years off treatment, you can see, this treatment was very effective in the sense that we're getting substantial reductions, around about 20 to 30%, and that this persisted for 2 years after stopping the treatment, exactly as we'd previously shown in adults, and I'll show you this data again in a moment. So, and also when we look at asthma symptoms and medication use, just asthma symptoms, asthma medication, the combination, FEV1 reversibility plus symptoms, or symptoms plus intranasal inhaled corticosteroid use, then there is a clear signal in favour of prevention of asthma symptoms as opposed to time to onset. So I think the primary endpoint was probably wrong in this trial. I do believe there's a signal here, both for subcutaneous and sublingual immunotherapy from previous studies, that we can actually prevent asthma if we get in early and treat these kids with rhinitis. So what's the take-home message for prevention of rhinitis? This is my take-home message from the literature that I've gleaned. First of all, secondhand smoke in pregnancy and infancy is bad news. If you can't live on a farm, then you can start daycare between 1.5 to 3 years of age. Childhood vaccinations we know are a good thing, but although it might be good to breastfeed, there's really no recommendations that we can make in terms of breastfeeding, dietary manipulation, or PETs in terms of prevention of rhinitis. Highly controversial PETs, whether they make rhinitis or asthma better or not. Prevention of rhinitis. So just what we can say is that we can prevent progression, and we can prevent in terms of primary prevention, I think this is what's for the future, if we can get in there with sufficient doses of sublingual treatment. So in terms of treating asthma, we can try house dust mite avoidance, and all the previous sublingual the previous avoidance studies have been spectacularly unsuccessful for asthma, all the interventional studies. But there's some good news. There was a study recently from Adnan Kustovic published in the Blue Journal that shows that in children aged 3 to 17 years, if you have aggressive house dust mite avoidance measures in the home, then you can reduce the hospital attendance with asthma exacerbations. And we know that the interaction between allergy and virus exacerbations is very important, and that you can actually reduce that by giving by rigorous allergen avoidance measures in children. And this is the time to onset of the first exacerbation in those that underwent avoidance measures compared to those that didn't. And finally, just to say that immunotherapy, we know, is highly effective. We know that we can't give it in patients with asthma, and it doesn't work in patients with multiple allergies. We can give it by the subcutaneous or the sublingual route. If we give it by the subcutaneous route, it's highly effective in terms of reducing symptoms. This is a dose-response time course study showing in 410 patients in the UK, you get a 30 to 40% reduction in symptoms and rescue requirement within 6 months of starting. We know that it's effective for house dust mites. Recent studies, there are a dozen studies in the literature showing that if you give house dust mite immunotherapy to adults and children, that it can be highly effective in treating house dust mite-induced rhinitis. We know that if we give it for a period of 4 years and then withdraw over a period of 3 years, this is for subcutaneous treatment, that we can reduce the symptoms for 3 years after stopping the treatment. This is using conventional high-dose subcutaneous treatment. This has translated into, in adults as well, that if we give sublingual treatment using tablet treatment for a period of 3 years, that we can reduce rhinitis symptoms, and that this persists for 2 years after stopping the treatment. So this is inducing immune tolerance. Antigen-specific, antigen-driven tolerance. You give the treatment for 3 years, you get long-term benefit for 2 years after stopping it. A recent study we published this year was, what about 2 years? Is that enough? And we compared subcutaneous and sublingual head-to-head. This was published in JAMA last year. And essentially what we show compared to placebo is that both sublingual and subcutaneous treatment is effective in suppressing nasal challenges, but it bounces back at 3 years. And similarly, if we look at peak inspiratory flow after nasal challenge, we get a very good protective effect, but this bounces back if we stop after 2 years. And this just shows you one example here using the peak nasal inspiratory flow up to 10 hours. This is work from Guy Scadding in our group, showing very nicely that in years 1 and 2 you have a dramatic reduction in the response to nasal challenge with grass pollen. This is during both the early and the late phase response, highly statistically significant, and this effect is lost at year 3. And these are dramatic effects which are not statistically significant at year 3. And this translates into seasonal disease. If you look at the quality of life of these patients during the summer, you can see that sublingual treatment with high-dose grass pollen sublingual treatment or subcutaneous treatment is very effective at improving quality of life during 2 consecutive seasons. This is the pollen count, but this effect is lost in year 3. So the take-home message from this study is that 2 years is not enough for long-term tolerance. You have to give the treatment for at least 3 years for long-term tolerance. So the take-home message for you is that both treatments are highly effective in seasonal disease. They induce long-term remission, high-quality evidence. They are effective in perennial disease, moderate for subcutaneous treatment, very high-quality evidence for sublingual house dust mite immunotherapy. The indirect evidence suggests that SCIT may be more effective than SLIT, but on the other hand, the evidence base is that SLIT may be safer than SCIT. We need a lot more data in children because we've got a strong database in adults now. We need to look at children. And essentially, both treatments, what's the downside? Both are associated with local side effects. SCIT, in view of the risk of anaphylaxis, needs a specialist clinic, whereas SLIT can be given in the home. But of course, the problem with that is one of compliance, and it's very important that we are obsessional and see our patients 3 monthly to make sure that they're taking their tablets on a regular basis. And we do a tablet return thing whereby they have to bring back the empty packages before they get the next supply of treatment. We still need to do additional comparative studies. And as in all things, you have to ask the patient whether they prefer to take a tablet or injections, because the indications are the same for SCIT and SLIT, and the patient's decision is an important one. So where are we? I think the balance, actually, the patient is in equipoise. I think SCIT may be slightly more effective, but on the other hand, SLIT is certainly safer. And if you look at my globe here, you can see that in the States they're leaning towards SCIT still, whereas in this country and Europe we're swinging very much more over in favour of sublingual treatment. And I think this is a trend that might continue. So in summary, ladies and gentlemen, there's not much going for preventing rhinitis at the moment, and I've listed those things that we can use that are important. But what we sure can do is we can treat patients effectively for allergic rhinitis with intranasal steroids and antihistamines. If they don't work, usually it's because they're either not taking the treatment or they're not taking it correctly. But in that proportion of patients who fail to respond, immunotherapy is a great treatment, both for seasonal and for perennial disease. And unlike any other treatment, it induces long-term remission. Now, that's not a cure, but I think at the moment we're better at trying to cure rhinitis than we are at preventing it. And that's my final message. Thank you for your attention.